everyone. My name is Andrew Needles, Product Manager at VisualSonics. Thanks everyone for joining us on today's Q&A session looking at Vevo 2100 cardiovascular analysis. I'm joined today by Stephen Butters. Steve's an application specialist at VisualSonics, works extensively with Vevo 2100 in cardiac imaging. What we're today is really a new format for us. We've done these webinar sessions in the past, but this is the first time we're really going to focus on more of a question and answer type forum. This is based on feedback we had from many of the listeners and users of the Vevo systems. So we thought I'd try something new. We've got a number of questions that have come in through the registration. People have posted questions. I see some people are starting to post questions already using the chat window. I just want to make a few notes before we get started. We'll be recording today's session. And as I mentioned, please use the chat window because all of the lines are going to be muted. This is really just allows us to give a good quality recording, to eliminate the background noise. So please use the chat window for all of your questions. We are happy to take questions as we go. We will endeavor to get to all of them. There's already a number of questions that have come in and are starting to come in. So in the event that we do not get to your question today, we apologize in advance, but we will make every effort to contact you directly and have more of that discussion at a time. We will provide at some point our email addresses for both Stephen and myself, so you can certainly follow up with us directly. We expect a very short presentation today, just about 5 minutes, just to overview some of the basics of cardiovascular imaging with the Vevo. Approximately under 30-35 minutes of question and answer session. Just a reminder again, VisualSonics offers a number of webinars, and again, thanks for joining us today. Please look at visualsonics.com/webinars to look at future sessions, and please register for those. So without ado, I think we'll get started. I'll pass things over to Stephen. Stephen will show just a short presentation, and then move into the Q&A session.
Great, thanks, Andrew. And good morning, everybody. Again, thanks for joining us. As Andrew said, we'll just do a really quick overview, and then we'll move into the actual Vevo software and get a look at some cardiovascular images. And everybody that's on there, please go ahead and put questions in as we go. We have a few questions here that were submitted previously on registration. We'll try and maybe answer those first, and then we'll play it by ear and see what comes up. So, sort of we're going to start as just a basic overview, really just to get everybody on the same page. I wanted just to get everybody thinking about what the Vevo 2100 system is, what it does, what it can do in terms of cardiovascular imaging. In terms here, looking at things like B mode, grayscale B mode images, measuring the left ventricle here with the LV trace tool, and combining color Doppler and pulse wave Doppler together to look at flow in vessels. Those of you joining us who don't have a 2100 yet, maybe have a 770, the B mode, LV trace, and the PW Doppler may be familiar to you, but the color Doppler is not. Color Doppler is a 2100, Vevo 2100 only application, and it works very nicely for cardiovascular imaging to look at fast-flowing vessels, what you can see here in the pulmonary artery, and then home in on those specific areas to do your pulse wave Doppler measurements. And of course, any of us that are familiar with the system know the large array of measurements and calculations that are available in the cardiovascular packages, both in the 770 and in the 2100 as well. Just some examples here of some stuff in measurements of mitral valve and in left ventricle. Moving to more advanced analysis, the 2100 also has the capability to have the VevoStrain software added onto it, which is an echocardiography speckle tracking software. Allows you to look at velocity, displacement, strain rate in the short the long axis, radial, longitudinal, and circumferential directions. So it does produce a lot of data. It's very fine analysis. This, again, is a 2100 only thing. We did have a question that was submitted earlier during the registration process about VevoStrain. So I will get to VevoStrain in a little bit. I'll show more of the basic Vevo software and some of the basic measurements first, just to answer some of the questions. The VevoStrain is what we consider to be a post-analysis, post-capture analysis, and sort of more high-level analysis that allows you to really drill down more deeply into the data. And then just some things to be aware of, again, people that have used the system already or maybe thinking about using it. There's a lot of adjustments that you can make to your images, depth, width, gain, choice of transducer. These have a lot of effects on your data. Really, I mean, it's a garbage in, garbage out situation, as with most things. You really have to try to plan ahead, really select the best tools, really work sort of in your pilot studies to develop presets and develop settings that really work well for your particular subject animal, your particular models. Again, choosing the transducers. All the transducers for the system have specific attributes, things like the maximum Doppler that they can go to. There was a question that came in about TAC models, so I'll mention that in a little bit when we actually look at the data. Things like the depth and field of view to plan for the types of imaging that you want to do. You really need to do some planning ahead. Actually, all of what I just said also goes for the 770 as well. Transducer choice is very important on the 770, especially because a lot of the attributes for the transducers on the 770 are fixed. One thing you can do nicely on the 2100 is have this ability to have applications and presets. So when I mentioned about the various things for the images, you can create your own presets on the 2100, which is nice, and I really try to promote people doing that. It's very important to have presets, that are working for you, for your models, and to really have those planned ahead of time and be able to standardize things in your experiments. So all of the things that you see here in this block can be set as presets and saved in your system. And then just some important things, and this also goes for the 770. The gain settings are very important because the gain settings actually change the underlying data on the system. The brightness or the darkness, quote unquote darkness of the image, can make it more or less challenging to do your measurements later on. Whereas other things like the brightness and the contrast on the 2100 specifically, again, things like the dynamic range and the display map, these are all things that can be changed afterwards, post-capture. So just some important things to think about when you're doing acquisition. So that concludes the PowerPoint part of the presentation. So just had a very quick, very basic overview of the 2100s and just about a couple of the modes and things, the V mode and the color Doppler pulse wave, and I mentioned VevoStrain and some of the image settings. So I'll move into the Vevo software right now. So this is the Vevo 2100 software for analysis, for post-analysis. And one of the questions that we got ahead of time was a two-part question. The first one was taking consistent heart ultrasounds for mice over time points. So a couple of things that I wanted to point out with that. One thing would obviously be the positioning of the animal in the imaging session. So that's going to be very important for how the image is oriented. So actually I've got two images to bring up here to show. The first one, this is obviously long axis left ventricle. You can see that the air outflow tract and the apex are not completely lined up with each other. They're fairly close, but the apex is kicked up a little bit, versus this image, which is from the same animal, the same imaging session, is just following a slight adjustment. And this one here, which is even better. So in this one, the aortic outflow tract and the apex are a little little bit more lined up. That just comes from animal positioning, from using the rail system, using the table, the ball joint where underneath the table where the mouse is to, excuse me, proper angles and positioning. Now, these can vary a lot between animals, even between different animals, different species, or sorry, different, not species, but different strains. And even between the same animals from the same cages in different imaging sessions. You may notice sometimes that the heart is in one position in one animal, and then one of its cage mates, one of its litter mates, the heart is twisted a bit or turned a bit, or the apex is turned up a little bit towards the rib cage. So play around with the angles a lot. Play around with the angle of the ball joint underneath the table where the animal is, and also the angle of the transducer and how that relates to the way that the transducer is sitting across the animal's chest. We do have an imaging guide, imaging guides both for the 770 and the 2100. They're available on our customer website, and I can flip into the PDF of the imaging guide maybe in a little bit, and we'll talk a little bit more about animal positioning as it comes up. In terms of consistency, being consistent and taking consistent measurements and consistent images across time, heart rate and the temperature are very, very important. The heart rate and the temperature are displayed here. On the bottom below the image, you have the ECG trace and the respiration trace, and then the body temperature here. These are all, of course, monitored off of the table. Those of you out there that are using the system, it's very important to monitor the heart rate of the animal and really manage the depth of the isoflurane or whatever anesthesia you happen to be using in the animals, and not depress the heart rate too far. And as we've discovered that body temperature really has a critical effect on the heart rate and the blood pressure in the animal physiology. So using the heat of the table, but also using a heat lamp above, and when you're imaging, keeping an eye on that body temperature and really trying to keep it in a tight range. If anything else, if you can almost ignore, for lack of a better term, the heart rate. If you maintain the body temperature within a fairly tight range, the heart rate and the physiology will follow from there. So those are really important things for being consistent. Just monitoring that physio data and really trying to keep it consistent. In terms of optimizing the images, we mentioned the animal positioning, the positioning of the transducer. One thing I wanted to point out here in this image are the shadows. So depending on the resolution of the screen, what you're looking at as this is coming through here, there's a rib shadow right here, and there's another rib shadow right here. Those rib shadows will always be there, but you can move them around a little bit with positioning of the transducer and of the animal. So what I often tell people is if you're interested in, say, the AV valve and the coronary arteries and things that are going on up here at the base of the heart, put rib shadows down to the left, towards on the left on the screen, towards the apex of the heart, and then you get a clearer image of the base of the heart. Conversely, if you're looking at something like infarct models, where the infarcts tend to be down in the apex, push the rib shadows up towards the base of the heart so that you get a clearer image of the apex and the infarct regions and the hinge points between the infarcted and the normal tissue. So just a positioning thing strictly, and then also optimizing things like I mentioned in the short PowerPoint. There are things like gain, the dynamic range, the width and the depth. These will all have the width and the depth and the line density on the 2100 will have a very huge effect on the frame rate. Frame rates are very important. The higher the frame rate you can get, the better. So you can affect on the frame rate by using the cardiology application. The presets in the cardiology application already have things optimized for higher frame rates, and then play around with the settings and create your own presets with things like the width, the depth, and to try and bring the frame rates up, and then use the gain try and decrease the noise. With dynamic range, you can try to increase or decrease the amount of grayscale. I often equate dynamic range to contrast setting because it will increase or decrease the amount of gray versus the amount of black and white in the image. And sometimes a lower dynamic range in cardiovascular imaging is a bit better because it makes the image a little sharper around the endocardium. Sharpens things up a bit. Another thing is it's not obvious on the screen to anybody people that have never looked at a 2100 image before, but there's a line right here alongside the scale. This line represents where the TGC, the time gain correction settings are. On the 770, there's actually a software block up here in the corner of the TGC settings. On the 2100, these are hardware on the keyboard. And so they allow you to adjust the gain throughout the depth of the image. And often for cardiovascular imaging, we will drop the gain at the top to try to reduce some of the brightness from the skin line, and also drop the gain at the bottom to try and reduce some of these compression artifacts that you see in the far wall in the image. So lots of settings on the system, on both systems, but especially on the 2100, and play around with them to try and really optimize your images. The question that came in about whether or not presets are available on the 770, the most accurate answer for that is sort of. The presets are not available on the 770, in the same way that they are on the 2100, where you have a clear indication here that you have a preset up in the upper left of the screen, and that you have a save preset button, where you hit a save preset button and it pops up, and you can give it a name. That's all very 2100 specific. On the 770, if you make your settings for width and depth, which on the 770 are sector X and sector Y, you can adjust things like the pen in the window, which changes the offset and the depth offset, and also the viewing level where the window is. Change your TGC settings on the screen, and then you can actually go to Operator Preferences, and in the Operator Preferences window, there's a set of buttons. One says Load Custom, Save Custom, and it's actually save a custom file that has the sector X, sector Y, the TGC. It also has the global system gain setting as well, and also I believe the image invert, the left-right invert on the image is saved to that file as well. It doesn't give you a clear indication on the screen on the 770 that you have that preset, but if you know it's a specific preset, you can just go into that Operator Preferences window and recall it and work with it from there. So I'll move on to another question that was sent in earlier. This is also a two-part question. This is specifically about rat imaging, and I'm actually just realizing right now that I don't think I have any rat cardio, but I do have some rat livers, so not exactly within the area that we want to look at, but I will bring up one image just to point something out, and that's actually not what I was expecting. Let me try something else. 50. Okay, so when we do rat imaging, we use rat cardio. We usually use the MS-250. Obviously, this is a rat liver, but I just wanted to bring up this image just to show the panel here. So the MS-250 probe is a 21 megahertz center frequency probe. And those of you that know that have used the system, that have different transducers or that have worked with ultrasound a bit, as you change the frequency, so as you go down frequency, you drop resolution. And so one of the parts to this question was about the image quality not being as sharp with the MS-250 as it maybe is with the MS-400, which is the 30 megahertz center frequency, or with the 550D, which is a 40 megahertz center frequency probe. That's another one that we tend to use sometimes for mouse cardio imaging. So traditionally on the 2100, the mouse cardio imaging would be done with 30 or a 40 megahertz center frequency probe, depending on the size of the animal, versus rat is generally done with this probe with the 21 megahertz center frequency. When you change that frequency, you change resolution. So you actually have different slice thickness, different axial and lateral resolutions between the probes, and you end up with different speckle size. So the speckle sizes on the lower frequency probes, the lower you go, the bigger the speckle size is. And it gives the appearance that the image is a bit linear. The thing that can throw people off sometimes on our systems, the 770 and the 2100 both, as compared to a clinical system, is that we don't do nearly the amount of processing, smoothing, or using persistence and things the clinical systems do. Clinical systems do a lot of post-processing before the image is even displayed, and it tends to give a smoother image. Our images tend to look a little bit grainier to people that are used to clinical systems, and it's because we don't do that processing of the image. We don't tend to use persistence. You can see here on the left side that the persistence is shown as off here. Persistence is available on the system, but we don't tend to use it unless it is called for in something very specific. I've used it sometimes in, say, contrast imaging of a tumor, or sometimes even in liver imaging, just to kind of smooth the granularity of the organ out a little bit. So it's normal to see that. I can actually show you here. This is, again, a 250 image, and if we go back to a previous image that I had here, this is, so this is also rat liver image, but this is with the 400, and it doesn't look as quite grainy. And then if we look at the previous B-mode images that we had up here, these are with the 550D. So going up in frequency between these three images, we've gone up from 21 to 40 megahertz. It's going to look a lot smoother because the pixel size is a lot smaller. So that's one aspect of, one part of this question. Another part of the question was about, and again, specifically with the MS250, with frame rate and going to VevoStrain. So this gives me a good lead in to go to VevoStrain. So I've actually got some VevoStrain data here already that I'll call up. I'll go to the actual image first just to have a look at it. Frame rate, very, very important with VevoStrain. Minimum off, we feel from the testing and the usage that we've done here, is around 120 frames per second. So you never have to worry about that with mice, that 120, because the mouse images, again, were at higher frequency, the actual size of the image is smaller, the resolution is greater, so the frame rates tend to be quite a bit higher. However, when you go to rat cardio imaging, you're using that 21 megahertz probe again, so you end up with a much lower frame rate. You really have to work to optimize the image settings. So cardiology, the presets are normally going to have standard line density, and they're also normally going to have one focal zone. That's going to drive the frame rate up. But with the 250, with the 21 megahertz probe, you're going to be dancing right around the edge of 100, 110, 115, 120 frames with just the basic settings. So you have to work a little bit to optimize the width of the image. You may run into issues with older animals that have larger hearts, or say animals that have high tension models, things like that, where they're getting hypertrophy, where the hearts are enlarging. You may run into some issues there where you can't quite fit the whole heart of the screen, so you have to sacrifice a bit. Now on this image here, actually just let me play a little bit so we can see. To do VevoStrain, we really only need the endocardium and the epicardium of the heart. We don't really need the aortic outflow tract and the right ventricular outflow tract and pulmonary here. So we could actually trim this image width in. If you can see where I'm making a line with the arrow here, we could bring the width in to here, right at the base, right at the AV valve, as long as we don't lose the apex here, so we can keep the edge of the image here. And on the beats, obviously, and on the rest, on the peaks of inspiration, as the animal is breathing, things are moving a little bit, so you have to have a little bit of wiggle room on both sides. But you need to squeeze that image right in. And if you think about what I'll show in a few minutes when I actually go into VevoStrain, you really, with VevoStrain, are only looking at a section from about here on the endocardium around to about here. So if frame rates are getting tight, if you can try it, if the heart's large, if you need to squeeze it, you can actually squeeze it in a little bit more. You even go past the AV valve. As long as you have the apex and the whole area that you want to trace with VevoStrain, then you're going to be fine in terms of analysis for data. So I'll jump into VevoStrain. I just want to double check and make sure, yes, this is the image that I already have. So we'll go to VevoStrain. It takes a few seconds to load. In applications, we do tend to recommend doing VevoStrain on the workstation, on a laptop or a desktop system, rather than on the imaging system itself. This is assuming, of course, that you have a desktop or a workstation install available. The computer that's inside the imaging station is dedicated really to driving the boards and actually doing image acquisition. And it's the specifications on it are a little bit lower than it might be for, say, current laptops and current desktops. So the amount of processing that VevoStrain requires does tend to work better on a desktop, on a modern desktop or a laptop. So this is the VevoStrain main analysis window. Actually, I just realized I just skipped a step. So we can actually go back to the M mode selection. So into VevoStrain, this is the window that you're going to be presented with. You need to draw an anatomical M mode line down here, which I have. So this is just a single click left and then left. This will give you the anatomical M mode window across here. This allows you to select some periods, some sections to do the actual analysis with. So to VevoStrain, two things to remember. Not a good idea to load more than 300 frames in VevoStrain. 300 frames is a lot of data. 300 frames will give you this long anatomical M mode strip to work with. So this is a lot of cycles to work with. For VevoStrain analysis, you really only need to do 2 or 3 vascular cycles for analysis. You don't need to do 4 or 5, 6. You're really just increasing the amount of data and increasing the processing time by doing that. It's really not necessary. So that's where I say make sure that you're only putting around 300 frames in. That will give you the selection, the ability to select a few cardiac cycles here. For anybody that's interested, when I pop back out to the regular Vevo software, I'll show you how to change the amount of frames that you're putting into VevoStrain. So when you drop this anatomical M mode line down, you get this panel across here. Now you can select the segments, the cycles that you actually want to use. So we can move this slider and we can take these few cycles here. If you're doing freehand scanning and you don't have the ECG, the R waves may or may not be detected. You can actually delete the R waves. So if I hover over here, there's an X. I can actually delete these R waves, and I can put R wave back in if I go to the area where I see the full dialate, and again, a little bit of a sync. Let's put it here, so I can put one R waves in. So this works if you have, say, if you're doing freehand scanning, or if you did have the animal hooked up to the physiology where you have the ECG, you can actually add and subtract your own R waves. So when you have the segment selected, that your trace, this is a long axis. We're going to do endocardial and epicardial tracing at the same time. I do not recommend for tracing going beyond roughly about this point, because beyond here, you're getting into the area where you're bumping up against the RVOT in the pulmonary, and the motion here in this thinner septum area tends to be a little bit different. And the same down here, you're sort of getting close to, depending on your view, the atria and the mitral valve down here. So try to keep your tracing a little bit shorter. I think some of the literature that we have for VevoStrain that we produced early on had us extending the tracing right out to the edges here, and we've discovered over time that that's maybe not the best approach. That doing something like this is a little bit better, just to keep it a little bit smaller. So then we'll go in, we'll run the analysis. And so now we're into the tracing that we had here before. So now we've got what we call the main analysis screen, so we can play our image. We can look at the vectors. So there's a setting over here on the right side for vectors, looking at trace points, so you can see how the points are moving through the different cycles, or just look at the actual tracing itself. itself. So the pictures is a kind of a nice view because it shows you the twisting and compression motion of the heart altogether. We have selectors obviously up across the top here for things like velocity, displacement, strain we can look at, and strain rate. So the two segments here, radial strain, longitudinal strain, I want to point out it's very important for VevoStrain is if you do the endocardial tracing but not the echocardial tracing, you will get data for radial strain. The data for radial strain is arbitrary. It's not necessarily reproducible. It's just the way the software works. So what we recommend is do the endocardial and echocardial tracings together, and that way the radial and the longitudinal, or if we were doing short axis tracing, this would be circumferential instead of longitudinal. The information will be correct and will be reproducible. So what we're getting up here, and here in these graphs is a mapping of all of the points. We can actually go and select a few individual points, and you can see if I place a point here at the apex, you actually see on the tracing as I'm clicking to place points, then colored dots showing me where those points are on the endocardium. And now we've got the tracings at the top here, so we've just got these three individual lines now for a point. So you don't have to deal with all 48 points all at once. You can choose to select a few, 2, 3, 4 points in different sections that you want. As you do that, obviously you get them for longitudinal and radial both. And then we change through strain rates, or back to velocity. We're getting the data for just those points specifically. If we want to go to mapping all points again, just click here to reset, and reset back to mapping all points. That's just endocardium. Down here in the history, multiple tracings. So if you have tracing that you're sort of not happy about, you can do another one, or you can go back and edit the previous one that you did, or you can actually go and create a new trace, and those histories will accrue here. We can flip to the epicardium now, so you can see up here on the B mode image, the vector points have flipped out onto the epicardium. We have the same selectors, velocity, displacement, strain rate, mapping the individual points. Down bottom left here, we've got some systolic and diastolic parameters, ejection fraction, and the LV masses, and also the change in volume by the change in time mapped here. So that's a quick overview of the main analysis screen. These are exportable. You can export AVIs, JPEGs. You can export a CSV file of all of these data as well. And then if you go to the time peak analysis, we get time to peak strain in this case, radial and longitudinal, for this particular cycle. So this red box here gives you the cycle, and you can actually jump to different cycles. Where did that box go? I forget where that is. You jump through to different cardiovascular cycles. You can actually also adjust the size of the box here as well, and take in a couple of cycles if you want to average. A lot of people seem to like this screen because it takes the heart, quickly divides it up into 6 arbitrary sections, and gives you the time to peak, in milliseconds, to peak percentage of strain, radial and longitudinal. The segments are here, so it gives you 1, 2, 3, 4, 5, 6 numbered. It gives you asterisks here to show you where it actually starts numbering them. So it's posterior base, posterior mid, posterior apex, then it flips back over to base, mid, and apex on the anterior side as well. And gives you the, I remember where that button is now. There's an R to R button here that allows you to jump to the different cardiovascular cycles. So you can cycle through and look at the different cycles that, based on the R waves that the system has traced out. So you can just cycle through and look at those averaged. Again, these are all exportable as well, so that these data are exportable to CSV files. So you can get those data. I will say that this is a lot of data. CSV files are big. They have a lot of data in them. They have all of these numbers for each component, so velocity, displacement, strain, and strain rate, by time, based on frame rate, and by point, which is 48 points. So you get CSV file is divided up into huge blocks of data that you can then sift through. I would highly recommend doing that with Excel macros or some sort of scripting language like Perl or Python. Dealing with that amount of data by hand is pretty difficult. So I would definitely recommend making friends with somebody that's pretty good at doing some scripting programming in Excel or in Python to help deal with that amount of data. I did want to jump back to the Vevo software for a second, and I wanted to point out an adjustment that you can make here. And actually, I will go to a different study that has some very long clips in it here. So these clips are 1,000 frames long. If you remove VevoStrain, I would not recommend putting that many frames into VevoStrain. It's a lot of data. It will slow the system down, and you may end up with some weird errors from things like buffer overflows and memory issues. So I would recommend making the clip smaller before you go into VevoStrain, and you do that here at the side where it says 1,000 or 1 here. You see a little hand pops up. You can click that and move it down to 300, which is a more reasonable size clip. Now when you go into VevoStrain, it will take these 300 frames and put those into VevoStrain. And you don't have to select those 300 frames, obviously. You can select frames from any section. So if there's a particular segment of a clip that you really like, this is especially useful if you're freehand scanning. As you're moving around, sometimes there may be only a small segment of the clip that you actually like for positioning or for view or for shadowing or something. So make adjustments there and then go into VevoStrain, and then that will make managing the data considerably easier. So I think that's about it for the previously submitted questions. We did have a question that came in, a few questions that came in, so if we want to maybe go through those.
Yeah, I think Stephen touched on the first part of this question, which was about the TAC models. Maybe you could speak a little bit about TAC models, some of the challenges with, really the question is, the cross-banding pressure is very high and the flow velocity is very high. And specifically, this user was using the 770 to a lower frequency transducer, the 710B. Which is a 25 megahertz transducer. As a result, they can see much higher velocities. Considering how that then would performs on the 2100, if you can, because they don't have the 2100, so they're interested to know how we would deal with that issue on the 2100. If you could just speak a bit about the relationship between center frequency and maximum velocity.
Sure. So I've just got a nice B-mode image here of a TAC model that I pulled up, so you can see in the aortic arch, you can actually see where the suture is right here, and how the ascending aorta is ballooned out right here. This is actually done with the 550D with the 40 megahertz probe. So as Andrew alluded to, as you increase, there's a lot of relationships between various aspects of transducers. So when I talked about the rat imaging and imaging with the 250 and speckle size and resolution, how that changes. Your field of view changes, your depth of focus, your depth of field. One of the things that changes with frequency is the maximum Doppler capability of the probe. So as you increase the frequency, the maximum speed of Doppler that you're going to be able to measure decreases. So if you're imaging models with a 550D, you're going to get really beautiful images of the aortic arch. You're going to get really beautiful images of the left ventricle, but the maximum velocity that you're going to be able to measure up to with Doppler is not necessarily high enough to get to where you need. So in terms of what the flows are. So if we look here with color Doppler, you can see that we've actually gone to the MS250 probe, and this has gone down to, because we're in Doppler, it says 16 megahertz. So remember, the 250 is the one that I talked about before. That's a 21 megahertz center. In Doppler, the frequency drops down. We've done that because the flows are so high here on the downside of the downstream side of the suture. we're at 4,800 to 4.8 meters per second flow coming out of the downstream side of the suture. That we've had to drop down to that probe to get Doppler velocity up to the area where we can measure. So changing probes is one important aspect. I guess maybe going back even before changing probes, having models that don't necessarily have extremely high flows. So if you go back to, say, design of experiment and work with the models to maybe not create flows that are off the chart for that particular probe that you have. And actually just alluded to that, speaking of chart, if anybody is interested, wants to know, either contact Andrew or myself. We have a Doppler frequency chart that we made up that shows all of the probes for the 2100 and the maximum Doppler speeds that they're able to get up to. So that might actually help you maybe do some design of experiment to figure out if you've only got, say, a 550D or you've only got a 400, how can you reliably go to measure, and then if you have the flexibility to go to even a lower frequency, a 250 probe, then you can drive those velocities up a lot higher. Big thing is going to be positioning. So when we get up to the velocity, it says PRF here, which is pulse repetition frequency, but on a 2100 keyboard, the knob is actually the velocity knob, and it adjusts that. So we've cranked it up. Cranking that velocity, that PRF up, changes the scale here. So we've maxed it out here to 125 kilohertz. When you get to that high velocity, on the Doppler line, you will see these teal bars here. On the 770, you would actually see extra gates. So you would actually see extra sample volume gates here. Those teal bars, and there's actually an extra sample volume gate just out of view here. You can't quite see it. That's due to pulse wave Doppler physics. So what you need to do is focus on the sample volume gate that is in the middle here that has the angle line on it. The other ones don't have an angle correction line on it. So you need to focus on the one that has the angle correction line on it. And they also need to keep it away from these teal colored bars. These are blockout zones. They have to do with pulse wave Doppler physics. I won't bore anybody with the nitty-gritty details of that, but measuring pulse wave Doppler within those blockout zones will be at lower velocity and will be less reliable than it is if you are out of those blockout zones and within this area. So how to do that is just simply positioning. The depth, the actual physical depth of the transducer as it relates to the animal on the probe clamp, because these blockout zones don't move. They stay static on this line, but as you move the Doppler sample volume gate, this area here, as you move this up and down, you can actually move it up and down the line. So if you physically position the suture here, this is a really good position because the downstream side of the suture is right here, which is right in the middle of the area to measure. Then we're well away from the blockout zones. We can place the sample volume gate right here in the middle and get the best measurement. So those are sort of all the range of things that I would say that you need to look at to adjust. In terms of comparison between the 770 and the 2100, the 770 is still a very capable system of measuring Doppler in general and TAC model specifically. Depending on the probe that you have, the 710B is a good probe for doing that. Again, it's a 25 megahertz center frequency probe, so that will get you fairly high maximum Doppler. I would say that you probably come close to that with the MS400 probe on the 2100. That's the 30 megahertz center frequency probe. You're going to sacrifice just a little bit. I think the MS400 drops from 30 down to around 26 or 27 megahertz for Doppler, so it's fairly close to where the 710B is. If you do have models that are showing jets that are higher, then you may have to go down to the MS250 probe, the even lower frequency probe, just to get your maximum velocity.
Okay. That's good. And I just pointed out to everyone, we did add our email addresses for both Stephen and myself, so we can, if you do have more specific questions, and for this specific listener who is asking about these Doppler velocities, we can certainly send along that sheet that you were talking about that allows you to calculate ahead of time. But I think really the point that you can see, sometimes there really is a trade-off in terms of the resolution and the maximum velocity. So one other point I'd add, there's actually another transducer called the MS250S, which specifically optimized for shallow imaging at 20 megahertz. So that's, again, a nice way of looking with a bit better resolution at lower frequencies to give those high velocity maximums. So yeah, just to clarify, we will email the document out to the listener that was asking about the maximum velocity. If anyone else is interested in that, please let us know with a quick email. There is a follow-up question from the same listener, but I think that question is probably better dealt with offline. It was very detailed in terms of how to position for a specific view. So yeah. In that case, we will take that one offline, because I don't think we're really going to do it justice here over the WebEx. And there's actually one other question that came in very recently, and I thought, Stephen, the question is, I'm having trouble with exact definitions of borders between IVCT, EET, VRT in Doppler flow analysis. Could you explain them? So if you could just clarify with other people who aren't sure what some of the acronyms are, IVCT, AET, sure. VRT.
Sure. So I'll actually start with a B-mode image. The C-mode image of the apical four-chamber view. So we've got left ventricle here, intraventricular septum here, right ventricle here, just slightly shadowed by the sternum, and then left ventricle and right ventricle down here. So what we're looking for in this image, and again on 2100, we have capability to go with and look color Doppler. We want to look for mitral valve flow. So if we look in color Doppler, we can see that's actually not a great image. Let's go and see if I had a better one. No, I don't have a better one. Okay. Looking for, with color Doppler, this to blue flash over here. Let me speed up the play a little bit. So there's a blue flash, red-blue flash over there that we're looking for. That's the mitral valve flow. So if we go look at now, so now we found the four-chamber view in B mode. We checked it with color Doppler, so we're looking. We know for sure that we're looking at the correct flow. We're looking at the mitral valve. Now go ahead and we place our Doppler sample volume line, and we get mitral valve flow. So we've got a mitral valve trace here. This is very typical. Again, this is a normal mouse, nice mitral valve trace. The heart rate was 460 BPM, so the separation between the E and the A peak is pretty good. If we go to the measurement panel, we got mitral valve flow. Here's where the acronyms that Andrew mentioned in this question: IVRT, IVCT, NFT. So if you're working on the system at any time, well, actually, even before that, in the user's manual for the system, in the appendices in the back, all of the measurement packages are detailed. All of the acronyms are laid out for all of the different measurement packages. So all of these acronyms are all broken down, and all of as measurements, and then the calculations that are subsequently derived from those measurements are also laid out. So when you get your report and you see things like MVAET or LVCO, things like that, those are all laid out in the appendices of the user's manual. If you don't have the big bulky user's manual handy, when you're actually on the system, the help is accessible from the study browser. For anybody that's using the system, this is a slightly different appearance of the study browser. I'm actually running an alpha build of the software. So on your systems right now, because you have you're still running the currently released software, there'll be a help button up here. When you go to that, you can actually get the operator manual, and all the sections of the operator manual are laid out here, searchable. So if you're in front of the system and you're wondering about something specific and you've got a few minutes, you can flip through the operator manual there. What to point out, though, that's really handy for when you're imaging is pull up any measurement package and any protocol from the measurement package and go to the help button here. Now, with the help for the AE flow protocol, which is the one that I selected, all of the measurement acronyms are all defined, and all of the calculations which will be derived from those measurements are defined. If I go back to the image and select M flow, mitral valve flow, go to the help. Now we got help for the mitral valve. Again, all of the acronyms and all of the calculations which are subsequently derived from those. So to look these up here, so the acronyms are IVRT and IVCT are the isovolumic relaxation and contraction times. The NFT and AET are the non-filling and the aortic ejection times. So the placement of these measurements are laid out in the measurement guide. Again, so I recommend checking out the customer website and looking at the measurement guide. To place the measurements, I'm actually going to increase the sweep speed because the way it is right now, if this is very tight together, it's sometimes very hard to see where to place these measurements. I want to actually increase the sweep speed down here on this slider, and I'm going to stretch those peaks way out because I want to see spaces in between them because this is where the IVRT and IVCT measurements go. One other thing that I'm going to do is I'm actually going to slightly increase the brightness just to kind of brighten the lines up a little bit. Just a personal thing that I want to do. So IVT, volumic relaxation time. It's this point where the flow comes back up to the line to the beginning of the E peak, and we'll move that out of the way. Isovolumic contraction time is on the other side. So if you think of the relaxation happens before the E peak, and then the contraction happens after the A peak. So that's where the A peak hits the lung and where ejection starts to happen. So I want to move that up out of the way. So that's IVRT and your IVCT. IVRT goes on the left of the E peak before the E peak hits, and the IVCT, the contraction, goes on the downside just after the A peak when everything snaps shut. The non-flow time and the aortic ejection time go here. So this is the aortic ejection time. This is this whole downstream side. The flow is actually flowing out. This is the aortic ejection right here. The flow time is the entire span from when the A peak hits the baseline to when the E peak starts. So you can consider that the IT and IVCT and the aortic ejection time and the NFT are kind of combined together a little bit, where we're looking at similar things. And if you go to the report, you'll actually get the myocardial performance index measured in two different ways, one using the IVRT, IVCT, and one using the NFT, AET. So that's where those placements go. So the AET is this ejection here. The NFT, the non-flow time, is the whole span between the A and the E. IRT is here, and IVCT are here.
Great. So even when you're placing those points, are you actually using that zoom window on the left side to really hone in on exactly where you want to start?
Yes.
And end those points?
Yeah, I am actually, and that's a good point. Whenever you select a measurement off of here, you get the zoom window that shows up here on the left side over here. So this area here is the zoom window, so you can see in very closely how to place those measurements. And when I'm placing these measurements specifically, especially the ones like the IVCT and the IRT that are in very small spans, I'm using a combination of stretching the sweep speed out, so making the whole trace a little wider so that you can really see where to place them, and then looking in the zoom window here to really home in on where to place those points.
I'm just going to take actually two questions that came in from different listeners, both about anesthesia, so I thought we could probably tackle both of them at once. One just asking which anesthesia is used. Now, I'm assuming that's for the majority of the images we see here, and I think you mentioned isoflurane.
Yes.
The question again was just about, for optimal imaging, should the inhalant isoflurane be controlled as shallow as possible, or do you have an optimal isoflurane flow rate?
So we've found, going around to all the different labs and different users and the work here, everybody has sort of different approaches, but my personal preference is to try to keep the animals as light as possible. What I talked about earlier with looking at the heart rate and the temperature. So I prefer to try to keep the animals light, try to keep the heart rate up high, and again, just to monitor the temperature with the heat lamp. So I would say I generally set the flow rate at around 1 to 1.5 on the vaporizer when I'm imaging mice, and for rats maybe sometimes a little bit higher, although I do try to keep the rats pretty light too, so 1, 1.2, 1.5. In terms of the flow rate on the vaporizer for the propellant, either oxygen or metal air, try to keep the flow rate on at around 0.8. I think some of the earlier documentation, some of the earlier training stuff that we had said, I think I can't remember if it's liters per minute or milliliters per minute. I can't remember what the scale is. I try to keep it actually a little bit lower. I try to keep it at around 0.8 for mice. You do have to drive it up a little bit higher for rats, sometimes just because of the increased body weight. That's what I've generally found with ISO. Now, there are people out there using different things like sevoflurane, which I've never had a chance to use. And I've seen people using injectables, things like phenobarbital or ketamine xylazine, which are not recommended for cardiovascular imaging. They really depress the blood pressure, and the physiology is kind of all over the place. So we found that light isoflurane and tight temperature control, try to keep the temperature up high, close to the animal's normal body temperature, really I think I said off the top, if you monitor the body temperature, then the heart rate will fall as long as the isoflurane is light. Okay. Yeah.
Just going to take one last question, because we're running a little on time at this point. I don't want to keep people longer than we Stephen, I'm going to throw this one at you. I'm not sure if you actually have any of this data or not. Just about aortic valvular flows and pulmonary flows. Do we have any of that data? And also for aortic stenosis and pulmonary hypertension.
Okay.
So general question just about those particular models, and I'm not sure if you have that data.
I do have pulmonary. I've got some good pulmonary images here. So these are just ones that I took off of a normal animal here at the lab. So this is just a V mode. Staying up from, you can actually see the progression. If we go back to the long axis, which is about here, so you can actually see the progression of going from long axis up slightly towards the aorta, and then tweaking the plane of view slightly here to get the pulmonary. So this is the pulmonary flow here. The aortic outflow tractor here, and on the other side. And if we go to Doppler, here's where you can really see it. So we've got really good pulmonary flows here. You can see in the blue here, there's very slight aliasing of the color as blue jet of the pulmonary aliases over to, there it is, to white and then into yellow and red. So this is the reliable velocity area flow. And then if we go to the pulmonary PW Doppler, I think I've got, here we go, this is the best one right here. So some good pulmonary PW Doppler flows right here. Again, these are normal animals. There's a set of measurements here. So there's a few different measurements. The pulmonary is kind of interesting because there's multiple measurements. You can actually measure the RVOT, the pulmonary valve, and the pulmonary artery. So these measurements give you the ability to go from one side of the valve to the other. So if you're taking PW Doppler measurements upstream of the valve in the RVOT, at the valve, and then downstream of the valve in the pulmonary artery. So these are really functional, again, if you're looking at pulmonary hypertension models. Once you have your PW Doppler trace, the standard, pretty much the standard measurements would apply. You've got this is pulmonary artery. So the VI measurements, the volume time integral measurements. So we'll just place those really quickly. That gives you a nice the volume time integral, heart rate, VTI, velocity, and pressure gradients. You can measure the pulmonary max velocity. Two that are on here that I do in the pulmonary, and I would also do in the aorta. And again, we'll just take the speed, we'll stretch the sweep speed out because we're going to focus on this peak here. We're going to measure the pulmonary acceleration and the pulmonary ejection. So we measure the acceleration from the line from where it starts to the center. And that's actually why I'm using this one, because I already have the center marked. And then the ejection time is going to be the full run from the start over to finish. We've got acceleration, so the upslope here, and then ejection time. So these are both baseline measurements. These are useful in pulmonary hypertension models when you're looking at the flows changing in the pulmonary artery. This set of measurements I would do also in the aorta, at the aortic valve, looking at aortic stenosis models as well. I don't think I have any pulmonary hypertension images, but I think I do have. I probably have ascending aortic images that I can show. Yes, I do. Actually, I don't like that one. Let's look at ascending aorta mode. This is a suprasternal view, and again, the different views, the long axis, the apical four-chamber, the suprasternal view, these are laid out in our imaging guide. So if you grab a copy of the imaging guide, you can take a look and see what those different types of views are. You can see the color Doppler here, so I've switched in B mode. I've gone directly to PW Doppler, and I think this one actually has a set of measurements in it here. Yeah, so this is the ascending aorta. Again, same set of measurements: peak velocity, VI, aortic ejection, and aortic acceleration time. So if you're looking at stenosis models, these are obviously going to change. And then if you're looking at pulmonary hypertension models, again, those values are going to be all over the place. The different measurements are there to allow you to look at those different types of models. I mentioned the different measurements that are available in the pulmonary. So the VOT, the valve, and the actual artery itself. Similarly, you have some different options in the aortic protocol as well. You've got the LVOT and actually measuring within the aortic outflow tract. So you can measure on one side of the valve and the other. So that gives you a little bit of flexibility.
Great. Well, everyone, I think just in the interest of time, we're running a little bit past 9 o'clock here. And I actually just want to say I think it's been a great session. I want to personally thank Stephen for all his time and effort and putting in the detail to answer all these questions and getting all this data together. Really a new format for us today, this Q&A type session. But I mean, personally for me, it was really satisfying just to see the level of detail that users are getting to the questions they're asking. It's really very exciting to see. So again, thank you, Stephen. Thank you, everyone, for listening. In the event, I know there's a few questions we didn't get to every single question. We'll follow up with you with some answers and take some of these discussions offline. We'll also be emailing you both a survey and a recording of today's session. Please, take some time and fill out the survey. We'd love to hear your comments on today's format and the content. If there's anything you'd like us to change or do differently in future sessions, we'd love to hear from you. Again, thanks to everyone. We'll send them with the survey and the recording. Please check out our website for upcoming webinars. You can see the link here on the screen, visualsonics.com/webinars. And I hope to hear from many of you soon. Again, thank you, Stephen, and thanks everyone for listening. And we'll be
email us. And email either Andrew or myself or both, or VSI support if you've got any other questions to follow up on, anything that we didn't get to or anything you want some clarification for. Andrew and I are both available to help us out.
Right. The emails we've just put up. You'll also in the chat window our emails and also the the link to the customer website. I do encourage you to take a look at that imaging guide on the customer website. There's quite a wealth of information there to help you answer many of the questions. So again, thanks everyone, and hopefully to speak to you again soon. Bye for now.